Everyone for the invitation. I want to really begin also by thanking the Vice Chancellor for being here in person. I will not try to pronounce his name. I am 2 centuries removed from my African roots and I've lost the ability to pronounce some names, so please excuse me, but I'm very pleased that you could be here this morning with us. The WR also, who I previously met actually in Brazzaville. I would also like to thank Dr. Seman Kambo. In fact, he's on a technical working group working with me now in Geneva. And of course, I cannot forget to thank Professor Chikuli. I hope I pronounced your name correctly. I know there's been a lot of work on communication going into making this event possible. So I thank everyone. I want to say that everything I've heard so far is completely in tune with what I'm about to present to you. I've been given quite a period of time and it's there. Okay. And I'm glad I have, because there are a lot of things that I've heard that I would like to expand on this morning. And I feel that my job here today and for the rest of the week, but certainly this morning, is to let you know what we are doing at a global level, to actually build on every single thing that you've been talking about this morning. And I've been wondering, has everybody here actually been in headquarters? Have they been at some of the global conferences? Because all of the themes are very relevant. This photo, just before I go on, I'd like to show you here, is a number of graduates in South Africa. And they were graduating from a master's in public health with an emphasis on human resources for health. And it was a special program designed by WHO and led by headquarters, but funded by the Bill and Melinda Gates Foundation. And a number of graduates from Mozambique, Rwanda, Ethiopia and South Africa went through this program. And I wanted to feature it because I feel it is one of the things that we really need to feel proud of, that there's a lot of South-South collaboration going on. This was a very strong consortium that over a period of 2.5 years, they trained several people, one of whom is now a state minister in Ethiopia. And many of them, as a result of their training, have actually been promoted. So there's something very good about what you are doing. I feel very strongly that you're on the right track with the work that you're doing here. So what is the purpose of my presentation? Well, I want to talk a little bit about the context in which the policy recommendations that you've heard mentioned, transforming and scaling up health professional education and training, how they were developed and some of the challenges we faced. What was our response as WHO? Because at the global level, we are very much a normative organization. And looking at the key policy issues and recommendations themselves coming out of the document, and I will be very happy to send as many of these documents as necessary to the WHO Country Office for distribution. And finally, but not at all least important, look at a global assessment tool that WHO is developing that is really bringing together the implementation of these guidelines in a very concrete way. And as I said, Dr. Seman Kambo is actually on the technical working group, which is a global group, working with me at headquarters to make this a reality. So let me start by a brief reminder. I'm not going to go into a lot of this, but the brief reminder is just to show you what a dire situation we've been in the world. I know you can't see some of these countries, but remember back in 2006, the World Health Report that was published said that there was a crisis in 57 countries across the world, and there was a very severe problem with doctors, nurses and midwives in particular. Not that these were the only groups, I very much stress, but these were the groups for which we had the most information. So you would see here, I want to say that down at this end we have Somalia and Guinea. and El Salvador up at the other end. And just to also say that this was a critical threshold that WHO was working with at the time, and these are the 57 countries. So you can see how dramatic the situation was in some countries in the world. And of these 57, as you know, 36 in sub-Saharan Africa. Now, getting straight to the issue of education, which is what this conference is about, I need to take you on a little journey of what we've been doing in WHO and how we've reached where we are today. So even though this is not the very beginning, because someone did mention the Joint Learning Initiative going back to 2004, I think it was the WR, that preceded by 2 years the 2006 World Health Report. But I want to take you on the beginning of this journey from the World Health Report perspective, because I want you to see where we are now, what we've done, and where we still need to go. So back in 2006, we said, okay, this was the pipeline, and the pipeline was meant to generate and recruit the health workforce. So we had a pool of eligibles, which were usually high school students, or people from other professions who wanted to get into health professional education. They were selected, they went on accredited courses, there were training institutions at different levels. Don't forget, we have tertiary here and professional, but do not forget technical, because technical and vocational education is something that's important, that's been a bit neglected. And of course, once they graduated, they became potential workers in these different categories, and they were licensed and declared fit for practice and recruited into the health workforce. And we had migration and attrition. Now, this is a fairly straightforward explanation of what happened, but life is not so simple. Since 2006, you see on the Working Together for Health, the World Health Report there. In that year, the World Health Assembly made up, it's now 194 member states with the addition of South Sudan, but the World Health Assembly passed a resolution which called for the rapid scaling up of health workforce production. And when you hear the term World Health Assembly resolution, it means that the member states are essentially telling WHO, this is your job, this is what you've got to do. But if we then look at the trajectory from 2006 to 2013 and beyond, we would see that there have been a lot of resolutions passed, as well as important declarations like, is this clear? Can everybody see it clearly? Is it okay? Can you see at the back? Oh, they're saying no at the back. I don't. Better? Yeah, great. Yes, it was looking a bit fuzzy to me too. I thought I was nearsighted. So we have a number of other important documents. We see the Rio +20 political declaration on social determinants of health. We see the primary health care, World Health Resolution on health system strengthening. We have the UN Platform for Health and the post-2015 agenda. We have all of these things, and amongst these, it was the resolution that was passed on health workforce strengthening that talked about transforming health professional education. And this really, in WHO, was the birth of a lot of what we are talking about now. It's not that it wasn't happening, but there's been a sea change and a momentum building up around this. And nursing and midwifery is part of this. So this is when the guidelines began, this is when they were birthed. And before the guidelines were published, last year, we then had a resolution calling for transforming health workforce education in support of universal health coverage. And that's where I will talk to you at the end about this global assessment tool. But I just want you to keep in mind that you would see this has been a movement. The world has been moving as WHO has been moving, and it's been pushing us and we've been pushing it. So it's a two-way process. So what are some of the forces driving the health workforce? Well, going back to the World Health Report, we know that what the challenges are: numbers, skill mix, distribution, working conditions. I don't have to repeat this to you, you know this. and the driving forces behind it. But what we had not done as WHO, we had not produced global guidance. In 2010, there were guidelines produced on access to health workers in remote and rural areas that address issues of working conditions, compensation, non-financial incentives, and workplace safety. But then, last year at Recife, at the third Global Forum on Human Resources for Health, we produced guidelines on education. You would see here that these guidelines on increasing access to health workers in remote and rural areas did contain a category of intervention on education, but we felt it was sufficiently important to take it a step further, both because of the issues that were taking place, the different declarations, the recognition that issues around social determinants of health is increasingly important and needs to be taught, and is not always taught systematically, but also that there was a particular need to place an emphasis on health professional education and training, because unless you get it right in the pre-service stage, and even before, as I am now convinced, that everything else after that, you would be producing more of the same. We've heard the WRC talk about the commission report. Everybody must have read the Lancet Commission report, I assume by now, that produced in 2010, on which we built some of the guidelines. So we decided to develop global guidelines. And what do I mean by global guidelines? WHO cannot be prescriptive, but what we have an ethical responsibility to do is to look at what are some of the critical issues in health professional education that would take it from where we say it is broken and help to try to fix it. But this is a partnership. So as I stand here, this is not something that WHO dictates to the world. It's something we do with you. You tell us this is what the issues are. We get some of the best brains in the world together. Unfortunately, we can't get all, otherwise we'd be bankrupt. But we get some of the best brains in the world, and we come up with global guidance. It's a long, systematic process, which I can talk about later if you really want to know, but I won't go through now. But it's built on evidence, and sometimes evidence can be your friend, and sometimes it can be your enemy, because there isn't enough published evidence sometimes to say what really needs to change. But we on the ground know. Those of us who've worked at the grassroots level in hospitals and clinics, who've seen patients, we know what needs to be done. So at the heart, what is the aim of transforming and scaling up the education of health professionals? Well, it's an expansion. So we talk about quantity, you know, we talked about the 57 countries, I showed you the diagram, but it's not only the 57 countries actually. Even in developed countries, there are problems, there are shortages in remote and rural areas, and sometimes there are problems even in slum areas, there are underserved areas. So, you know, don't look at it through rose glasses. It's not only, we say, in the developing world. If we talk about low and middle income countries, we have problems in high income countries too. So it's the expansion and reform of health professionals' education and training to increase the quantity, which we've talked about, but what we haven't talked about yet is the quality and the relevance of health professionals, to both meet population health needs and expectations, because everything we do must start there. When we developed these guidelines, that was our starting point. We started with what are the needs of the population, and then we worked backwards. And the other thing was to strengthen countries' health systems and improve population health outcomes. So the aims then were to define and provide guiding principles, not being prescriptive, as I said, not going down into the nitty-gritty, guiding principles for transforming and scaling up health professionals' education, to provide policy and technical guidance, particularly but not exclusively in the area of pre-service education, particularly to countries experiencing shortages of health professionals. The 10-step process there is the steps that we need to go through when we produce guidelines. And this took 2.5 years, so it's a very thorough process. The third aim was to foster integration of continuing professional development as part of health professionals' education and scale-up, because one of the things we were told by people who were faculty on our team is that not enough of this is done, or it's done with donors coming in and doing it in a haphazard way. No, we're saying it needs to be systematic and it needs to address the needs of countries. So we don't want more of the same. So who did we consult? Again, in listening to everyone talk this morning, it is clear that there's a very clear understanding of the need for multi-sectoral dialogue, because one of the things the Commission showed, the Commission on Health Professions of the 21st Century, was that the education system and the health system have been going their way merrily and not collaborating. So what did we do for this? We consulted, I would say, in a fairly intensive way, about 300 people over the course of 2.5 years, or 2 years before the guidelines were published. We looked at we spoke to regulatory bodies, professional associations. So we had meetings, we had reference group meetings. We spoke to people in the public and private sector, to education institutions, to community groups, to development partners, because we cannot ignore the fact that they have a strong influence on what happens at the country level in terms of funding. And of course, we included different ministries: health, finance, labor, education, and so on. And the aim, as we said, was to address and improve population health outcomes. So the key policy issues and recommendations, and let me say why I put both policy issues and recommendations. When you see the document, and I will show you the web link later on, there were many things that we looked at that we wanted to make recommendations on, but we could not, because the published evidence was so poor. And I am speaking to you now, and I hope you are listening, to you who are researchers and who publish. You have to publish more. We do not have enough robust global evidence from low and middle income countries to make strong recommendations that push policymakers, governments, that allow us to advocate enough for change. We may know it in individual institutions, but at the policy level we have to work very hard if there is not enough evidence. So I'm saying to you, we are falling down in that respect. When we did systematic reviews, we did not come up with a lot of robust evidence, as I would show you shortly. But we did say that in the areas of governance and planning, regulatory frameworks, education and training institutions, financing and sustainability, planning, implementation and evaluation, it's under these headings that we came up with the recommendations. This is what you, as in people from training institutions, policymakers, civil society, all the others I showed before, this is what you said were important. And we've put them into these guidelines. These guidelines are on the web. I will show you the link later. They're extremely heavy documents. And we have policy briefs as well. We have 5 policy briefs that actually elaborate on some of these areas. So I wanted to just show you very quickly how much there was an overlap, or how can I say? At the very heart of what you're discussing over the next few days, this is what we have said is important in the guidelines. We globally, I'm not just talking about WHO, but we globally have said. So you mentioned all the areas in red there, those are recommendations in the guidelines. All of them we've touched on in the guidelines. The one on e-learning, it is not a recommendation, but it's one I desperately wanted to get in there as a recommendation. But since the guidelines were launched last November in Recife in Brazil, I've actually commissioned 2 systematic reviews, which will be published shortly and made available on e-learning. And one of them, done by Imperial College London, looks at what is the evidence for the use of e-learning in pre-service education? Very critical, because many countries are using e-learning, but they're not always sure what works, what doesn't work. But what does the evidence say? So we now have systematic reviews, Cochrane reviews on pre-service education, and there's one that's going to be published later this year, which has been completed also on in-service training. So again, when I say in-service training, I want us to start thinking of lifelong learning. You know, and when I say lifelong learning, I'm not just talking about when you decide to become a nurse or a doctor or a pharmacist or a dentist. We're talking about transformation. I want us to start thinking, what happens even in the secondary school? How are we preparing students who want to become caregivers for the rest of their lives? What are we doing? So I'm not just talking then about continuing professional development in a very static way, but I'm talking about lifelong learning. And the others in green I've put up there because these are issues that we would like to get more information on our website, but I'll speak to you about the website a bit later. So let's look at what the recommendations are. And I hope you take lots of notes so you ask me questions, because this is quite a lot of work that went in over a long period of time. So it's going to be difficult to say everything, even in the time that I have. So these then are the recommendations that, based on these 300 people roughly that we consulted over 2.5 years, they said. Faculty development, we said that health professionals, education and training institutions should consider designing and implementing continuous development programs for faculty and teaching staff, because the faculty told us they don't do enough of it. And it must address evolving healthcare needs. We know there are emerging and re-emerging diseases. There are all kinds of issues that need to be addressed, and faculty need to be kept up to date. It's no good, you know, you were trained a couple of decades ago, you need to keep being refreshed, and we're saying that this is something that should be seriously considered. But look at it, the quality of the evidence when we did the systematic reviews was moderate, and therefore we had to make a conditional recommendation. We couldn't say, yes, everybody must go out and do this, because the evidence was moderate, and this is how we make recommendations. It doesn't mean it's not important, because the document actually gives background on what are the implementation considerations and a summary of the evidence. So for each of these in the document, you have summary of the evidence and implementation considerations. Under faculty, which is the only recommendation, we had 3 recommendations only for faculty. So that says something really important, that governments, funders and accrediting bodies should consider supporting the implementation of higher education policies for mandatory, and we had a lot of discussion over this, mandatory faculty development programs. So it shouldn't be a choice. For you to remain faculty, you should keep up. And the third one was that we should consider innovative expansion of faculty through the recruitment of community-based clinicians as health workers, because many faculty also told us that, you know, you have to have a PhD before you become faculty, and that puts constraints on training and the numbers of people who can be trained. Curriculum development, again, one of your sub-themes, that health professional education institutions should consider adapting curricula to the evolving needs of their community. So again, stay focused on what is important, okay? Look at what is critical at the national level. That is the thing that should drive your curricula. And more, we are very clear that social accountability is at the heart of curriculum development, and that's something that we are doing as part of the implementation of the recommendations. Simulation methods, there was a lot of discussion as to why we should put in something so specific, but there was talk earlier of technology moving fast. But there's also something such as appropriate technology, not just technology for technology's sake, not big beautiful machines that, you know, when they get broken, people don't know how to repair them. I lived and worked in Aceh after the tsunami. I was witness to very sophisticated mannequins for midwives lying in a room that was locked because nobody trained them on how to use it. Electricity didn't work for some of the machines. Some of them came with the instructions in Chinese. They were never used. So we're talking about appropriate technology, not just technology for technology's sake, and not implying that there should be second-class technology for low and middle-income countries. No, we are talking appropriate technology here. Direct entry of graduates, this was another area we had quite a lot of discussion and tussle over, you know, especially direct entry midwifery. Is it correct? Is it not correct? You know, what is UNFPA saying? What is UNFPA not saying? But we decided to broaden it outside just midwifery and say, well, what about health, people who want to become health professionals who might be from another discipline? So we had a recommendation that said institutions should consider direct entry of graduates from relevant undergraduate, postgraduate, or other educational programs. On the issue of admissions procedures, this is something I personally feel very passionate about. A lot more needs to be done to broaden the procedures for admission to health professional education. I'm thinking of places like Australia and Canada, where I've been, and I hear stories from people from First Nations communities and from, you know, Aboriginal communities. Do we think only, you know, 10 A-stars is important to become a good doctor? What are we saying about how do we admit people? What are the kinds of things we are looking for? And more we are seeing, working with UNESCO, I was astonished to find that children, even in primary school in Southeast Asia, there were 18 case studies done that show that children are being given good communication skills, what they call transversal skills and we call non-technical skills, but you know, communication, problem solving, anger management, all kinds of other things. And there's a lot of work going on amongst a group of education and training institutions that focus on social accountability, including the Northern Ontario School of Medicine that is practicing social accountability. They are changing radically the way they admit students, the kinds of things that they're looking for, and how they support them while they're in pre-service education. So the other recommendations, streamline education pathways and ladder programs, that health profession education and training institutions should consider using streamlined educational pathways or ladder programs for the advancement of practicing health professionals. You may do it in Makerere, but you would be amazed that many countries in the world don't do it. But look at that. The quality of the evidence supporting this recommendation is low. It meant we could not find enough robust studies to show that this actually works, even though among the 300 people we consulted, they said it was critical. So when we recommended it, we can only recommend it as something conditional, but I'm sure that you all know that it's something that's very important. Interprofessional education, more and more, I know this has been going on in several countries, but more and more it's being seen as something that really should be at the heart of how we teach at the pre-service level, and not just a timid thing about, oh, you know, you put a nurse with a doctor together and everything would be fine. No, it goes beyond that. You know, it is about teaching respect, understanding roles, but preparing people for intercollaborative practice. And this is where we're doing research in WHO. Can we find enough evidence of how interprofessional education supports intercollaborative practice? And this is one of the areas that we are working on now, coming out of the guidelines. And again, you would see the quality of evidence supporting this recommendation is low, which is quite surprising. And coming to the last two recommendations then, one on accreditation. I wanted to show you a video clip, if I can manage it on accreditation. One of the things we did coming out of the guidelines is we are making video clips for policymakers, which are only 4 or 5 minutes long, and they focus on what are some of the key issues at the country level, and then they give the recommendation. When we were doing this, we linked accreditation and regulation, but again, the evidence on regulation was so, it was not strong enough, again it's something surprising, to actually make a recommendation. But we have a policy brief which we provided, which again is on the website, on regulation, and it says that about half the countries in the world don't have strong regulation. Half the countries in the world. So it was quite a journey doing these guidelines with the evidence that we found. And last of all here, continuous professional development. We see that not only for faculty, but also obviously for health professionals themselves, that we are recommending it. And the quality of the evidence for this at least was moderate. But underpinning all of these 11 recommendations then, and I want you to know that behind each and every recommendation is action. These recommendations are not just words, but they are meant to be put into action. And some of this we are already doing with partners, and I'll mention a bit more about that. But underpinning these 11 recommendations, we are saying that government at the highest level must demonstrate political commitment to reform and take leadership, because it is in countries, you think of Thailand, you've been hearing probably, and Brazil and these places, it's because government has made a commitment. People know that they mean business. So these are one of the 4 good practice recommendations we say should underpin reform. We don't want reform to reach only to education and training institutions, as important as that is, but it must reach the level of educational policies, strategies and plans. And there is a need for formal collaboration and shared accountability. And that word accountability is loaded. It's absolutely loaded. It's not just accountability in terms of curriculum development, but accountability to the population. How do you demonstrate that? What are the indicators? And these are some of the things we're working not only with education and training institutions on, but with civil society, because they are really committed to the area of shared accountability. And the other 2, a national plan to produce and retain graduates is developed in consultation with stakeholders and aligned with the national health plan, and the creation or strengthening of national or subnational institutions must be done to support the implementation. So some of it might need to be in the form of legislation. Oops, what am I doing? Sorry. Okay. Did I miss one? No. Okay. I'm sorry, I think I'm getting a bit right. Okay. So, having said all of that, talking about transformation, talking about the journey from 2006 to 2013 and beyond, the work of the guidelines starting around 2011, and then the World Health Assembly resolution last year, which called for transforming health workforce education in support of universal health coverage. That diagram that I showed you at the beginning, we have had to transform that as well, because we cannot, as you say, be working in the 21st century with, old thinking. That was the traditional way of, you get them there, you get them in, you get them through, and you throw them out the other end. We can't take things that way anymore. We have to be aware that the world has become much more complex. I'm sorry I don't have a pointer, but you would see the white boxes, the pool of eligibles at my far left, and the boxes there correspond to the original diagram that I showed you. But what we are saying is that life has become more complex than this. We train health professionals, we're saying now, in systems, education system and health system must work together. We have to take on board the fact that social determinants of health must be integrated. We can't see it as an add-on or something that you stick onto a curriculum somewhere where it's convenient, right? There's been a lot of work done on this. So Michael Marmot has been working with us, and again, that's another one of the areas. We're going to develop an e-book on social determinants of health for health professionals. So we're saying, and also the post-2015 development agenda. 2015 is almost upon us. What are we doing? How are we as people who train health professionals taking this on board? Are we really taking it on board? Where is it reflected, not just in a curricula, but in the lifelong learning context? And so we're saying in order to achieve universal health coverage, actually we have to go back all the way to what are we doing about the pool of eligibles, because that's the only way we will contribute to sustainable development goals. And we have to work, the health sector has to work with and across other sectors. So we say these things, but the question is, how are we going to do it? How are we actually thinking of it? And this is a question I would put to you to think about over the next few days. How are you doing that? How are you recruiting people? What are your admissions procedures? Who are you drawing on for your health professionals of all types? Are you only concerned with the professional group? What about technical and vocational education and training? How is that linked to what you're doing? What about accreditation of your courses? Do you have strong regulation? All of those things that I just talked about. But you have to start thinking about the kind of people that you want even before you have them in the classroom. This is something as I said, I feel really passionate about, and we've actually started working with UNESCO on how do we address curricula, and working with the International Federation of Medical Students Associations as well, because they're very keen on bringing about change. They're at the cutting edge. They just left school and they're coming into university. I heard in January, there were 3 students who talked about their experiences. One was a doctor who said, after 3 years in medical school, I asked myself, why am I here? They're just teaching me things, and where's the heart in what you're teaching me? I'm doing simulation. I don't have much patient contact because some curricula don't allow intensive patient contact until much later. And this is what some of those schools practicing social accountability do. From year 1 they started in the community-based education. There are lots of things going on out in the world, people, that are transforming the way we teach, but we have to know where to look and how to harness them and how to adapt them. So this doctor was saying he was thinking of leaving medical school because he didn't see anything in it for him. He didn't just want to be spewed out the other end and just go earn money. That wasn't enough for him. Then there was a young midwife in the Philippines after the last disaster they had. I'm sorry, Philippines really is an unfortunate part of the world. They always have floods and hurricanes and so on. And she said part of what her university did, which was flattened, incidentally, it was in a remote area, it was flattened. She went back with other young students into the community. She was only like in her 2nd year or something like that, to serve. And for her, that is what it is really about. So are we producing enough of those kinds of people who want to put their heart and soul into it? And I cannot go on to the next section without telling you this short story, because it brought me to tears. When I was in Canada at a conference, in the Philippines, the University of Zamboanga, which is a rural university, and they have a retention rate of over 90% of their graduates. And they talked about very early in their pre-service education, having teams, you know, a nutritionist would go out with a doctor, would go out with a nurse into rural communities or even very remote. And they went to this community that was in a very remote area at the side of a lake. And as they approached the community, these young students, you know, there were shacks along the lake. They saw the people run indoors and close their doors and windows. And they couldn't understand why. So they left. They made another attempt sometime later. The exact thing happened. So what they did was they communicated with the elders in a nearby village. And they were told this. The reason why they ran and hid is because they felt they were so poor and hungry and dirty, nobody deserved to see them. And I was so moved by this story because what those young students did was they made links between the elders of the neighboring village and that village, and eventually they opened up to them. They established nutrition programs for the children. They built boats for the children so that they could go to school over the lake and take half an hour rather than 3 hours around the forest in the rain, where they had their little school uniforms in plastic bags so they wouldn't get wet. Okay? And they transformed the lives of the children and those villagers because very early in their career they saw themselves as delivering a service. They didn't sit in the clinic or the hospital and wait for them to come to them, because they would never come and they never would have seen them. But they went out there. And that program in Zamboanga, they practice what they call longitudinal integrated clerkships, where they start their training in the community very early. Doctors, nutritionists, dentists, nurses, midwives. And when they showed a picture of those little children getting into those little yellow boats in their school uniforms to go to school in the morning, having, you know, reduced the difficulties they had with nutrition and all the rest of it, I thought that is what we want in a health worker. That is what we should be aiming for. And this is what, when we were writing these guidelines and we talk about transformation, we are talking about a sea change, not waiting. I know this sounds old and stale, that, you know, you don't wait for people to come to you, you go to them. But in many parts of the world, our education does not train us that way. So keep in mind that transformation is more than just changes in curricula. So I want to address this last part, which kind of, not completely, but brings some of the pieces together, because there are a lot of things that we are doing, but I felt I needed to share this with you while I was here. One of the things that the World Health Assembly called on us to do last year, even before the guidelines were published, was to set up a working group. Well, they didn't call on us to set up a working group, but what they called for was the development of a standard protocol and tool for assessment to measure health workforce education. And it's meant to support member states to use a protocol and to assess the current situation in health workforce education, and then to provide technical support and report back to the World Health Assembly. So all of the things we were talking about in terms of transforming health professional education, what they're saying now is, okay, go out there and measure it. What is actually happening? What is WHO doing to measure what is happening at the country level? Go out there and do it. So what we've done is, I've put together a technical working group, a global group, made up again of people from diverse backgrounds, and we have come up with a conceptual framework, and in July we will have a meeting in Portugal to finalize it. And these three areas are the areas that we said we are going to focus on for global assessment. So this tool has to be, even though it would be tested or at the country level, it has to be aggregated globally. So we would be able to say, okay, maybe in Uganda, this is the status of health workforce education, but when we look at the region, this is the picture. So we are looking at research, health workforce education and quality of care. So what are we saying? We're saying that if you have to look at transforming education and measuring what's happening in education, we can't look at education alone. We have to look at how research is feeding into education to inform the need for changes in the curricula. We have to look at education in relation to service delivery and quality of care. And similarly, we have to look at is research actually helping, operational research helping us to improve service delivery and quality of care. And at the center of all that, we are looking at how it contributes to supporting universal health coverage. It's going to take a long time if I had to go through how we came to that, but suffice to say that this tool will be ready for testing in October this year. So just to give you an idea, if you look up here, I'm just looking at the one on the variables on health workforce education, and bear in mind what I've said before about what are we saying about what's important in education. So when we are looking at those variables that we want to assess, we are looking at primary, secondary, and non-tertiary education as well as professional education. We're looking at whether there's career guidance, whether there's non-technical skills included, how are students selected, is there direct entry, are there programs that help to support them, what is happening in curriculum development, research and training, simulation. Are they using community-based health workers as educators? Are they practicing interprofessional education? And all of those things under faculty development. Just a word on graduate outcomes. We actually have just completed a systematic review, which we intend to expand, which looks at 10 years after graduation where people are, because we don't know enough about where people end up. So we don't know how to plan well enough, and we don't know why they choose always what they choose. So we're doing graduate tracking as well. The e-learning, I've already mentioned that we're doing work on that. So these are when we look at those areas under education, we're asking countries, is it patient-centered, systems aligned, located in areas of need, faculty competent, is curricula based on needs, services, or competencies, or are they based on, what somebody else thinks you should be doing rather than what the problems in the country are? And is student selection based on a broad range of attributes and life skills, including these non-technical skills? And incidentally, I was recently at a meeting of the World Health Professions Alliance just around the time of the World Health Assembly. And they are doing work looking at the aviation industry and the oil industry, looking at what are some of those non-technical skills that are transferable but yet critical. And one beautiful example they gave was that one nurse was interviewed, and it was an operating theater nurse, and the doctor said to her, "Give me that buzzy thing." And of course, anybody standing outside listening would wonder what in heaven's name she was talking about. But the nurse knew exactly what the doctor wanted, and she handed it to him. Or sometimes the doctor would ask for something, but the nurse would hand him the right tool. So it's some of those things that they're looking at now, using evidence from the aviation industry and the oil industry, which is quite interesting. And training is actually going on in parts of Africa for scrub nurses and surgeons. So these are some, I'm only giving you a snapshot. So the tool then would look at, do a baseline assessment and evaluate what is needed. And then it would guide and inform transformation of the health workforce. And it would obviously be multi-sectoral and multi-stakeholder dialogues are needed at the country level and at the institutional level. And then based on that, it would enable countries to manage the change process. Several countries have already said, yes, we want to be part of it. And as I said, by October this year, we should be launching it. So this just shows, based on that diagram, when we do the initial assessment, the situation could look like that one there, where circles don't overlap because there's not connection between research and health service delivery. But at the end, what we are looking for is for countries to give some kind of commitment to where they need to be heading. So I've said quite a lot. For implementation, it would probably take me quite a long time, but just very briefly, in WHO, what we are doing for implementation of the guidelines is that I'm working across departments. So I'm working with the Department of Social and Environmental, Public Health and the Environment, with the people on e-learning, child and neonatal health, with the regions and the countries, inevitable, WHO regions and countries, across UN agencies, UNESCO, UNEP for social determinants of health. I should have mentioned Michael Marmot and his institution as well, with partners and collaborators, and you see the whole list there. I'm sorry, it's a lot of WHO jargon, but FDI is the dentist, FIP are the pharmacists, IHF is the International Hospital Federation. We're working with the US government through HRSA, with ICN, ICM, producing audio-visual material, photo stories from the grassroots, so looking at what goes on in villages, how are health workers at the village level doing things that are transformative. The video clips, I don't have any time to show it, but we've got 5 video clips already for policymakers. And we're working with electronic media. We have a website up, which I'm going to show you, and we're developing an e-book. So just a word on the website. I will leave the last slide up for a minute, but the website is meant to engage as many people as possible. It's got all of the documents for transformative education. We are trying to use social media, and at PMAC next year we're actually going to present a paper on how social media can be used to engage stakeholders but also influence policymakers. So we have all of that. We have blogs, we have tweets, we have the students involved, and we've just adjusted the website so people can upload documents of what's happening at the country level. We're creating a global map so we can have examples of transformation globally so that there can be ownership of what is going on. The assessment tools will be published, and the e-book, we have quite a number of people globally contributing to the e-book on social determinants of health for health professionals. And that's it. Thank you very much. Can I take this off?